Hello, cruel, cruel world. As my kind of tribute to Mental Health Awareness Week, I wanted to make this video, which is 6 misconceptions about deliberate self-harm. I'm also going to cover a couple of other questions, including why people self-harm and, crucially, do people self-harm for manipulation? There's lots of videos on the internet of people who do deliberately self-harm, but I thought it'd be interesting to actually see it from a psychiatrist perspective, so I've treated a lot of people with this presentation. I'm also going to briefly tell you about the most extreme case of self-harm that I've ever seen in my career. So sit back, relax, and welcome to A Psych for Sore Minds. So I think the advantage that I've got of talking about this is, as I say, I've assessed hundreds of self-harm cases, I think over maybe 100, 150. The disadvantage, I guess, is that I'm not speaking from a place of personal experience, so I don't know what it's like to self-harm. I'm very interested in stories though, so my dear viewers, A Psych for Sore guys and gals, if you've got stories you'd like to share, and if you don't mind sharing them, if it's not too painful, then please do let me know in the 𝐂𝐤𝐿𝐵𝐶s below. Okay, let's get started. Misconception number 1, that self-harm is a precursor to suicide. So deliberate self-harm, cutting oneself, etc., taking overdoses, and suicide have a very complicated relationship. Even if self-harm is not intended to be a suicide attempt, those who continue to engage in deliberate self-harm are eventually at an increased risk of suicide. So what I'm saying is that research has shown that people who have self-harmed who might not be initially suicidal but continue are significantly more likely to eventually. Does that make sense? So what I'm trying to say is that people don't start off necessarily with suicidal ideas but can do later on. Which is why when someone like myself, a psychiatrist, has to assess them, then we have to take everybody by case-to-case basis. And I will explain more about that and more about the motivations later on. When I worked as a junior doctor in a liaison psychiatry team, my role was to assess people who'd come in after self-harm. So most usually in the form of overdose. Sometimes they might have been brought in by the police, say trying to hang themselves, or because they've cut themselves quite deeply. And even though some are suicidal, from my experience, most are not, which is why it is really important to do a thorough risk assessment. So that basically means trying to figure out whether that person is safe to be discharged home into the community with extra support or help, or whether they need to come into hospital. And if they don't want to come into hospital, then sometimes I would have to section them against their will. So how do you do that? How do you do a risk assessment? I won't go through the whole thing because it's detailed, but to break down some of the simpler points, we look at certain factors of the actual suicide attempt. For example, if that person called an ambulance themselves, then it decreases the likelihood that they genuinely wanted to die. If they left a suicide note, that would increase the likelihood because they generally thought they would die. And it kind of depends on the circumstances. So did they actually try their best to cover up the attempt itself, or did they, for example, do it when they knew that somebody would come home, so that they knew that they'd be stopped, or they knew that they'd be caught, or did they text their partner as soon as they took an overdose, knowing that person would phone for the services? Now, I just want to be 100% crystal clear. I'm not saying for a second that any of this means that people who didn't want to kill themselves genuinely are not distressed and don't need help, or not, not depressed as well. I'm not saying that. What I'm saying is, as a psychiatrist, it's really important to decide those who are safe and those who are very likely to go and kill themselves if they're released. Because if you get it wrong, then obviously people can go and actually end their lives. So it's literally a life and death situation. The other thing is that when you do a risk assessment, is you have to know the context of what they did. So if it was an overdose, for example, what was the problem? Was it debts? And if so, can they be resolved? Can you refer them to somebody that can help, like social services? Is it relationship issues? Again, might refer them to social services. Were they maybe the victim of an assault? In which case you can refer them to victim liaison services. So what I'm trying to say is, it's really important to get to the crux of why somebody did what they did and see if you can offer help. By the way, if you're interested in any of this, I know it's a bit of a morbid topic, but I do think it's interesting. I've got a video, one of my first videos on this channel, I interviewed a very interesting man called John Clark, who was a police officer. He got PTSD from the horrific things he saw in his line of work. He tragically tried to kill himself and ended up being not arrested, but being taken away by the very police officers that he worked with and eventually sectioned into hospital. By the way, just as a side note, I, as well as my criminal cases, because I'm a forensic psychiatrist, I also do civil court cases. And sometimes I will assess people who, family members where the patient has committed suicide and the family members are suing the NHS Trust, and it's almost due to really poor risk assessment. Almost every case that I've seen has been related to that. Okay, before I move on with my misconceptions, I just want to ask you guys a question, my dear viewers, my Psych for Sore guys and gals. In 2009, can you tell me how many people you think committed suicide in England and Wales? And can you equate to how many that is every single day? Answers towards the end of this episode. Okay, misconception number 2. People do deliberate self-harm only to punish themselves. Well, I think that's definitely true in some cases, and that's because, sadly, people who self-harm are often, they have deep feelings of guilt, of shame, or depression. So a regular context that I would see it in would be the victims of abuse. So even though they're the victims, not the perpetrator, they feel kind of tainted, they feel dirty, they feel this deep guilt. So that's why they self-harm, to kind of punish themselves. However, separate to that, self-harm can also be like a maladaptive coping mechanism. So what that means is that sometimes when people self-harm, it releases endorphins, and it can actually improve their mood. Obviously, it's not a healthy way of improving their mood, and I would argue that in most cases it's quite temporary, but it can temporarily improve mood, or at least release intense stress. And that might be difficult to understand. If you're watching this, you might think, how can like, you know, hurting yourself improve your mood? But it does in some people. It releases endorphins. And my answer to that would be, there's lots of weird things that people do to improve their mood. Like some people are triathletes, they run marathons. To me, that's crazy. That would not improve my mood. It would just kind of hurt my ankles. Some people do things like stand-up comedy. Some people do cage fighting. So the point I'm trying to make is that just because you don't understand how that might help you in your mental state doesn't mean that it doesn't work for other people. The other thing that I'd say is that self-harm in adults is often linked to drug and alcohol use, causing disinhibition, which I'll come on to. And it's usually in the context of extreme stress. So because you're so kind of traumatized, or your mind's so busy by so many things going on, whether that's, you know, debts, relationship problems, maybe you're the victim of assault, that self-harming can help just wipe all those things away and focus your mind onto one issue. Having said all that, I do think that self-harm can occasionally be manipulative. So it can be in the context, for example, of a relationship, when you're forcing somebody to stay in the relationship. More on that later. All right, misconception number 3, that people who self-harm do it for attention. Again, as I will come on to, I do think that some people do occasionally, but definitely not the majority of people that self-harm. So one way that I know this is because I've seen many people who hide it. So for example, they might self-harm on their legs so that their school friends, parents, partners don't see the scars on their legs. And they keep it a secret. Sometimes people self-harm for years and manage to keep it a secret. So the point is that obviously these people are not doing it for attention. They might be doing it for help, which is different from attention, which I will come on to shortly. All right, misconception number 4. People commit deliberate self-harm for manipulation. So the crux of the matter for me when I talk about this is that attention is not the same as manipulation. A lot of people self-harm for attention. What I mean by that is they're trying to convey a message, and the essence of their message is this: I need help. That's what they're trying to say. And it might be, I've seen this in lots of different contexts, it might be that they have an unstable, unhappy relationship, maybe even a toxic relationship, but for whatever reason, they're not able to communicate that across. Maybe they don't have the communication skills, maybe the people around them aren't listening, maybe their partner or their family are not listening, so they don't feel heard, so they feel that they have to do something really loud to get the attention. So again, this is not manipulation to me, it's passing on a message, it's a form of communication. And by doing this, you're basically saying you cannot ignore me anymore when somebody presents to hospital, for example, with self-harming. Another context that I've seen it is when people are too ashamed to disclose something like abuse. They've been sexually abused as a child, for example, and by doing this, they at least open up the conversation. So it's a way in to start that difficult conversation. And I have to say, I'm not particularly proud of this. I'm ashamed as a psychiatrist, but I've definitely seen cases where people have have self-harmed to get the attention of the mental health team. So maybe they're tied into what we call the CMHT, Community Mental Health Team. Maybe their appointment's not for 4 weeks, 6 weeks, 8 weeks, and they're not particularly prioritized, so they self-harm so that they can kind of jump the queue. And I'm not saying this to criticize, I don't think we should judge, I'm just saying that it's not a particularly healthy way of expressing yourself. But you know, if you feel that's the only thing you can do to get the attention of the mental health team, then I understand. I can't condone it, but I understand why somebody would do this. Another reason that people might self-harm, somebody with like a learning disabilities or autism, they might self-harm like headbanging or burning themselves or hurting themselves because they don't have the communication skills to express that they're feeling really distressed about something. What I think is quite interesting is that everything that I've talked about, self-harming to try and send a message for attention, is often not understood by staff members, mental health members, and also A&E. So when I've worked in liaison psychiatry, I've worked regularly in accident emergency departments, and I would see that some members of staff would have very little sympathy for self-harmers, especially serial self-harmers. And to be crystal clear, I'm not supportive of this, but I can understand why people feel this way, why staff members feel this way. I think they feel that somebody who self-harms, especially when they do a pattern and they're offered help and they don't seem to accept that help, or they don't seem to change their presentation, the A&E staff feel that it's taking away from other people who need to be seen with life-threatening situations, and they feel like it's not a good use of their resource and their time. And even though I understand that point of view, my counter argument would be that nobody would put themselves in a self-harming situation lightly. There's always a reason why they would do that. So what I'm trying to say is that something needs to change. And it might not be the role of the doctor or the nurses. Maybe the A&E doctor and nurse can't be the change that that person needs to see. Maybe it's a relationship counsellor, maybe it's social services, maybe it's like a drug and alcohol rehab service, but they could at least act as a gateway to referral. So they should see that even though I can't help this patient, the patient is here for a reason. So we should refer them onto a service that can offer them help and not judge them. So what are your experiences, my Psych for Sore guys and gals? Let me know if you self-harmed or if you know somebody that's self-harmed, how you were treated, if you went to A&E department, the emergency department, whether you thought people were empathetic, whether they were fair or not. Let me know in the comment section below. Having said everything that I've just said, I also want to say that in my clinical experience, there can be occasions where people who self-harm are being manipulative. And I really want to stress that it is occasionally, it's not by any means the common thread. So I'll give you an example. I remember, it's a long time ago, but I remember that once there was this young girl, I think she was 17 or 18, and she took an overdose because her boyfriend was about to split up with her. When we did the risk assessment, we weren't that worried about the overdose. For example, she only took something like 6 paracetamol tablets when she had about another 20 to 30 at her disposal. She called the ambulance. No, she didn't call the ambulance, but she immediately texted her boyfriend knowing that her boyfriend would call the ambulance. She came in overnight, had a treatment. The next morning, she was kind of laughing and smiling. Her boyfriend had joined her. They obviously had made up from their relationship because they were kissing, canoodling. She was laughing and smiling in a bed. She actually self-discharged against medical advice. So I won't bore you with the details, but when you have a paracetamol overdose, there is an antidote called N-acetylcysteine. So you give it to somebody and you have to measure their liver enzymes every few hours to make sure that the liver's not permanently damaged. And the way that tests work is you have to wait for a number of hours to see which direction the enzymes are going in. So basically what I'm trying to say is she needed to stay in hospital for at least another 12 hours from the morning after she took the overdose. But she self-discharged against advice because she didn't want to stay around. So the whole point of this is there's 2 ways you could look at this. You could say that even though what she did was quite manipulative, at least the event somehow resolved itself. You know, she went back to her boyfriend. I mean, you could argue that's not a particularly healthy relationship, but that's, you know, a different conversation. Or you could argue that it was unfair on the A&E time and resources, overstretched doctors and nurses. There's lots of other people who are, you know, literally dying who need to be seen, road traffic accidents. So were her actions kind of disrespectful to those people because it puts them at the back of the queue, potentially risking their lives by making a delay in them seeing the doctors and nurses. But what do you think? Do you think that's a fair way to look at this, a Psych for Sore guys or gals? Let me know in the comment section below. All right, let's move on. Misunderstanding or misconception number 5, individuals who self-harm have been abused. Before I go into that, I just really want to briefly introduce you to my channel, Psych for Sore Minds. I am a consultant forensic psychiatrist. I assess mentally disordered offenders in courts and prisons and in psychiatric units. This channel is a smorgasbord of issues related to true crime, but all with a twist of psychiatry. Sometimes I interview people with experience of treating mental illness or who have mental illnesses themselves. Sometimes I psychoanalyze high-profile news cases, sometimes ridiculously evil criminals, and I give you my own psychoanalysis. I urge you to subscribe to this channel because not only does it help me out immeasurably, but if you do, then you'll never step in dog poo on the pavement again, guaranteed all your money back. If you're interested in the topic of suicide, which let's face it is a bit morbid, I've actually got a video called Is Suicide Selfish, where I look at the pros and cons of the argument. And I've got another video, really tragic case of a man called Adam Stanmore when he committed suicide, and it looks into the factors that caused this because it was investigated. And there's a big report released, so I go through that report and kind of educate you, my dear viewers, about how he slipped through the cracks. All of the links to those videos are in the 𝐿𝐿𝐿𝐿 below. Okay, let's move on. So, misunderstanding number 5, individuals who self-harm have been abused. Having a history of abuse can definitely increase the risk of self-harm, but not everybody who has self-injures has been abused. There are other much more common risk factors. Probably the biggest one from my clinical experience is drug and alcohol use. So why does drug and alcohol use increase the risk of self-harm? It's quite complicated and there's lots of different mechanisms. For a start, drug and alcohol use can lower your mood. So if you're more depressed, then obviously that means that it's more likely you're going to self-harm. Or it can cause you to be disinhibited. So if you've got vague thoughts of self-harm or even suicide in your mind, when you become intoxicated, you become disinhibited. You don't think through the consequences of your actions, so you might be more likely to self-harm when you're drunk or high. The other thing is that alcohol or drug use can be linked to social problems. To give you some extreme examples, if you're like an alcoholic, then you might have money problems, you might struggle to hold down a job, maybe your kids get taken into care. So all of those things, all those social problems will lower your mood and increase the chances of you self-harming. The other thing I'd say is that individuals who struggle with body image, such as eating disorders, that's another risk factors completely unrelated to abuse, which cause an increased risk of self-harming. Okay, final one, misconception number 6, that self-harming is always in the form of cutting. That's actually not true. That's probably one of the most common ones, with overdose being the second most common from the patients I see, but there's loads of different types of self-harming. There's burning yourself, there's like bruising yourself, biting, scratching, picking at wounds, and some people use rubber bands, and actually you could argue that's a healthier way of self-harming, so you don't actually physically damage yourself. It's to get rid of that kind of urge and release those endorphins. There's lots of different forms of self-harm is what I'm trying to say. Me personally, when I self-harm, I watch Dr. Grande videos.
Boom. Roasted.
Okay, here's an interesting one, and I'd like to know your thoughts. Some people, including psychiatric textbooks, would say that sexual promiscuity would lead to people self-harming. Sorry, I misspoke then. Sexual promiscuity in itself might be a form of self-harming. And I'm not sure that I buy that. I suppose it's not physical damage, but it's more about allowing yourself to be used or disrespecting your body. So it's kind of some of the same psychological processes of punishing yourself, but it's not physical damage. But what do you think? Do you think that's legitimately a form of self-harm or not? Personally, I don't, but as I say, you'll find that in psychiatric textbooks. Let me know, please. And also, my dear viewers, I'd like to know about your own experiences of self-harming, either yourself or somebody you know. What were the motivations? How did you feel treated? Have you heard of these misconceptions that I've told you? Have you heard them directly? Have you heard of any others, any big ones that I've missed? Let me know in the 𝐿𝐿𝐿𝐿 below. Okay, right, I asked you before if you could tell me the statistic in the United Kingdom in 2019, how many people committed suicide. The answer is, in that year, 5,691 deaths were registered as suicide. Obviously, that's a ridiculously high number, absolutely shameful. This is still happening. It's a big, big problem. And that equates to an average of 18 suicides per day in the country. So, I mean, that's almost 20 people every single day killing themselves. That really shows cracks in our society, I think. Okay, that's enough from me. I just want to quickly shout out another couple of videos. If you're interested in suicide, I told you about John Clark. I've also got a video on Johnny Depp and about him self-harming. I was going to tell you about the most extreme case of self-harm that I've ever said in my career, but we're almost getting to 20 minutes. I think it's too long. But what I'll do is, I'm sure I've discussed that in another video, so I'll put that link in the comments section below if you want to talk about it. Have a blessed day. Enjoy your life. Do not forget, I love you. Come and watch me at CrimeCon. Buy my goddamn book. Goodbye.